Okay, thank you so much. We will start in a few minutes, everyone. We'll just give an extra 3 minutes for people to join, and then we'll get going with the colorectal and general search. Okay, I hope that you can see the slides correctly. Let me know if not. So today we will talk about general surgery and colorectal surgery, everything in the abdomen below the epigastric level, as we covered that last week. If at any points you have any questions, either speak up and just ask. I will do my best to answer them. Also, feel free to write in the chat if you find that easier. As per usual, there will be a few MCQ questions peppered throughout, so I highly recommend joining and answering. Uh, I found that's how you learn the best, but again, to each their own. So, today we will cover general and colorectal surgery. We won't cover everything that's in the abdomen. However, we will cover a few key conditions, high yield conditions that are likely to come up in the exams, and disorders not to miss. So we will divide this talk into the acute abdomen, starting with the lower bits of the abdomen, and then we will cover central abdominal pain and chronic conditions as well. So, acute abdomen will be conditions associated with inflammation and surgical pathologies within the abdominal cavity. As you can imagine, there is quite a lot in there. We will focus mostly on the GI tract today. So, as you can see, anything from the esophagus to the rectum. We covered the upper GI tract, as I've said, so we will focus on the small bowel and a large bowel. We also have genitourinary system, uh, kidneys, ureters, bladder, urethra, and reproductive organs as well, which we will touch upon, the ovaries and the testes. Now, the important vascular consideration is we have abdominal aorta as well as its branches. Now, there are a few other causes of the pain in the abdomen. primarily radiating from the chest. However, you won't dwell on those today. Now, the best way to you are presented with a patient uh, in an OSCE abdo exam station or in history. One of the best ways to quickly stratify your differentials is asking about the location of their pain. Now, in real life, they might just say it hurts all over, but in exam and in the OSCEs, they will be a bit more helpful. Now, we covered all of the stuff that's happening at the top there, but we will cover a bit here at the bottom. Now, as you can imagine, if the pain is in the hypogastric region, it's unlikely to be pancreatitis. Right iliac flank is unlikely to be due to peptic ulcers, etc. Now we will cover the ones which come up most commonly, I would say. So the right iliac fossa pain and left iliac fossa pain. So there are several key differentials in there. Your right iliac fossa pain is classically appendicitis, and we will cover appendicitis today. On the left, we have the sigmoid colon, and with sigmoid colon, we have diverticulitis. We will cover a bit of Crohn's and ulcerative colitis today. Um, Importantly, in that region, we have the female genitourinary tract and the risk of ectopic pregnancies. Similarly, in the GU tract, ovarian torsion, as you can imagine, will present in the pain in the associated region, and testicular torsion commonly radiates to the abdomen. So we will cover that as well. And finally, but not the least, we'll cover the inguinal and femoral hernias, which are an exam favorite. Okay, so we will have our patient, 16-year-old boy, brought into the emergency department. Abdominal pain started in the center of his abdomen, migrated to the right lower abdomen. Vomited once, continuously nauseous. Fever, hemodynamically not too bad. Guarding in the right iliac fossa, and Rovsing signs is positive. Anybody wants to unmute themselves and say what they think is going on?
Appendicitis?
That is correct. Now, in terms of appendicitis, very common condition, highly likely to come up. And in terms of your patients, it will be 10 to 20-year-old, typically, essentially either an adolescent or a young adult. And the key thing is there is inflammation of the appendix. Typically, the typical history is of the periumbilical pain initially, and then it migrates to the right iliac fossa. The patients typically will complain of loss of appetite. They may not volunteer it initially, but you ask them and they're like, actually, I haven't eaten anything since yesterday. There may be nausea and vomiting. There is likely to be low-grade fever. And oftentimes, because of the pain, there is this classical vignette of them finding it very painful to go over the speed bumps on their way to hospital. Now, when you do your OSCEs and you do abdo exam, you will find that they are tender in the right iliac fossa. There will be guarding, and you want to be pressing at the McBurney's point, roughly 2/3 between umbilicus and the aces. A few different important things is that you may find rebound tenderness, which is suggestive of peritonitis and thus perforation. Now, important to recognize a few different key signs. We've mentioned Rovsing's sign. So you actually palpate in the left iliac fossa, and they feel the pain in the right iliac fossa. The psoas sign, you extend their hip, and it reproduces the pain. and obturator sign, which is you flex the hip and internally rotate it, and it can also replicate the sign, all of which point you towards appendicitis. Now, a common cause of appendicitis, it can be blockage of the appendix with a small amount of fecal material, which then causes the gut flora to multiply and triggers the immune response. We mentioned this is the McBurney's point, and here we have our maneuvers, with this being the psoas sign and this being the obturator sign. Now, part of your exams is how will you investigate? Always structure them in terms of bedside blood imaging, and rarely you will be wrong, and definitely if you are not sure. At the bedside, you can always do OBS and see whether the patient is very unwell or just a bit unwell, and it will also stratify your management. Important thing, however sexist it may sound, woman of childbearing age plus abdo pain equals pregnancy test. You don't want to miss an ectopic, as we will discuss in a minute. I will probably repeat it a few times, but at this point, definitely the equation of woman of childbearing age plus abdominal pain equals pregnancy test. Now on bloods, you can find in full blood count raised white cell count and raised neutrophil count, consistent with inflammation. Now imaging oftentimes is not required, as the examination with history and raised neutrophils based on the Alvarado score is sufficient to diagnose appendicitis. If you have a woman, especially if she is pregnancy test positive, if she's pregnancy test positive, you want to do transvaginal ultrasound and look for ectopic. Ultrasound is also helpful in visualizing appendicitis. Now the gold standard is the CT abdomen, which you would do if you suspect appendicitis, but you are not 100% sure the story doesn't fully fit, or if the patient is of unusual demographics. So you wouldn't really expect appendicitis in a middle-aged person or elderly person. Now, how do you manage appendicitis? So you will keep them nil by mouth, you will provide them analgesia, and you will rehydrate with IV fluids, give IV antibiotics, and this is where the medical management of appendicitis ends. However, most commonly you will proceed to laparoscopic appendicectomy, plus minus abdominal lavage if they've perforated and spilled fecal material all over their abdomen. Now, second presentation. 23-year-old female, right lower abdominal pain and spotting, shoulder tip pain and nausea, last menstrual period 6 weeks ago, saturating fine, but the blood pressure also fine, but the heart rate is a bit high. She's not really she doesn't really have fever. Anybody willing to volunteer top differential?
An ectopic?
Indeed. So this is an ectopic pregnancy. And ectopic pregnancy is it's implantation of the fertilized egg outside the main cavity of the uterus. Now, there are several sites where it may implant, but most commonly it will be the fallopian tube. Now, there are several risk factors you can elicit in history. History of pelvic inflammatory disease, which is associated with previous STIs such as gonorrhea or chlamydia. Having an IUD in place. So if you get pregnant or an IUD, it is more, you have higher risk of it going into ectopic pregnancy. Previous endometriosis, again, you get scarring within the fallopian tube, which is more likely to prevent the fertilized embryo from going into the main cavity, and smoking as well. Now, initially, it is asymptomatic, but it will present with the lower abdominal pain, which can be anywhere in the lower regions, classically right iliac fossa or left iliac fossa, but can be suprapubic. Ex in exams, this often radiates to the shoulder tip due to peritoneal irritation. You may get per vagina bleeding, typically dark brown, lighter than normal period. Recent history of amenorrhea, typically 6 to 8 weeks. This is roughly how long the ectopic can develop in the fallopian tube before it starts to stretch it and cause pain. And then we have dizziness and syncope if it has ruptured and our patient is bleeding into her abdomen. Now, what you want to do is, as we've said, urine dip for pregnancy test. Again, female, childbearing age, abdo pain equals pregnancy test. Now, the blood tests, you will cover this more in year 5 when you do your women's reproductive health. You may want to consider serial beta HCGs, which will remain stable, but don't worry too much about it at this stage. Now, the key investigation here is transvaginal ultrasound, as you will see an adnexal mass, so something happening in this area or this area that shouldn't be there, plus minus free fluid in the pouch of Douglas. Now, as for management, you would refer that to gynae, and they would perform laparoscopic salpingectomy, so remove the affected fallopian tube. Now, we are going on to patient number 3. It is busy day on SEU. You have a 16-year-old student, presents to the surgical emergency unit with 3-hour history of right iliac fossa pain, vomited once, he was playing rugby earlier in the day, otherwise fit and well, not really feverish, however he has high pulse, which is regular, pain, you look at him and you know that he is in pain, abdominal exam is actually unremarkable, and although he tells you that he has pain in his right iliac fossa, there is no local area of tenderness. Bowel sounds present. Then you examine external genitalia. You see a swollen, tender testis that is retracted upwards. Now, there is not much brownie point for telling me the most likely diagnosis, but I will give 1 or 2.
Testicular torsion?
Indeed. So, testicular torsion. Now, your patient will be male, or at least assigned male at birth. They will, in terms of the age, this is the condition of the adolescents or young adults. Again, you're unlikely to see it in the elderly gentlemen. And what happens is you have rotation of the testicle, which causes twisting of the spermatic cord, and that causes ischemia and later on necrosis of the testicle. Now, the risk factors is there is a congenital variant / abnormality called the Bell-Clapper deformity, which puts you at significantly higher risk of developing torsion. and it can be preceded by trauma. Oftentimes, the vignette will say that the patient was playing rugby or football or sustained trauma to their groin, but they haven't recovered from the pain and it continues to be excruciating. Uh, just like in the vignette we've just seen. Now, presentation is there is sudden onset and classically unilateral testicular pain. However, it is important to note that this can radiate upwards and there may be pain in the lower abdominal region without actually testicular pain experienced by the patient. So this is important OSCE point. If you have a mean examiner and they want to screw you over for not being safe, you will always examine the external genitalia because this is where the cause of the right iliac fossa pain may be hiding or left iliac fossa. And if you don't check, you won't see. Now, the patient oftentimes will present with nausea and vomiting as well. Now, on examination, the abdomen will be clear, but if you said that you will examine the genitalia, there will be the red, tender, or swollen testicle. It will be retracted upwards, and characteristic thing, especially in AKTs, is there is loss of cremasteric reflex. So a healthy testicle, if you stroke the inner thigh on the same side, the cremaster muscle should pull it upward, and this will be absent in testicular torsion. Now, in this case, you may really not do that much investigations. If you have it immediately available, you can do scrotal ultrasound, which will show whirlpool sign, but that is if you have it immediately available, as the key thing is you want to do surgical exploration, which is the gold standard for diagnosis. During that surgery, once they confirm that the testicle is indeed twisted on itself, they will untwist it, and if it's viable, they will perform orchidopexy, so fix it in place. They will fix both testicles in place actually. However, if it has been longer than 6 hours since the start of symptoms, this testicle has likely died, and they will just remove the necrotic testicle, but still fix the other one to prevent it from happening to the other testicle. Now, ovarian torsion is very much a similar type of condition, but now in females. Typically, it will be in premenopausal females, and this is where the ovary, plus minus the fallopian tube, will twist on its supporting ligaments, again leading to ischemia and necrosis. Now, the risk factors is the presence of an ovarian mass. In 90% of cases, there will be some sort of ovarian mass sitting there. However, it doesn't have to be anything malignant. It can be a simple ovarian cyst which precipitates that type of presentation. So again, we have the sudden onset right iliac fossa or left iliac fossa pain with nausea and vomiting. And to investigate, the key thing is transvaginal ultrasound, which will show you the whirlpool sign. And in terms of management, you keep the patient nil by mouth in preparation for the, again, golden standard diagnostic surgical exploration via laparoscopy. And if it's there, untwisting for treatment. Now, patient 4 comes through the door, and we are changing the demographic. We have 72-year-old female. She's taking regular laxatives and comes to our surgery. Now she has progressively worse pain, left lower quadrant. She is a bit feverish, around 38, but nothing too exciting. And again, she's tender in the left side of the abdomen. Who's going to offer me their top differential?
Diverticulitis?
Very well. It is indeed likely diverticulitis. Now let's talk a bit more broadly about the diverticular disease in kind of broader sense. Now, diverticular disease is extremely common. It will typically affect the sigmoid colon. However, it can affect the ascending colon, especially in Asian populations. And essentially, you have patients who have low fiber diet, who have chronic constipation for whatever reason, and the increased pressure in the bowel lumen leads to the outpouchings of the large bowel through the muscular layer. Now, you can subdivide it into three different conditions if you say. Now, diverticulosis simply means that diverticula, or these outpouchings, are present in that person's bowel. It is very common, especially in older population, and if it's diverticulosis, it's most likely an incidental finding on imaging done for whatever other reason. Now, diverticular disease is where it's symptomatic. Patients will present with uh, abdominal pain in that area, and diverticulitis is the dangerous one. This is where we have gut bacteria trapped in the diverticula. Again, potentially a bit of fecal material blocking uh, the tract, and this leads to inflammation. Now, diverticulitis, as you've correctly identified, is typically left iliac fossa pain. However, consider it in your patient with right iliac fossa pain if they are older, as a differential in addition to appendicitis. There will be change in bowel habit, maybe either, but more likely to tend towards constipation. With diverticulitis, what it differentiates it from the diverticular disease is there will be fever, they will be systematically unwell. Their observations will be bad. They may also have per-rectum bleeding, however, that is rare. Now, why do we want to treat diverticulitis? It's because it can go ugly if left untreated. We can it can lead to obstruction, especially with repeated episodes if there are several scars from the inflammation earlier. The diverticulum, if it's inflamed, can perforate and spill out the contents into the peritoneal cavity, and that can lead to infection. So we have peritonitis from perforated diverticulum, or the diverticulum can turn into an abscess. And then another possibility is the inflamed diverticula may cause a fistula, which is an abnormal epithelialized connection. So the structures close to it are things such as the bladder. So essentially you can have colovesical fistula with the fecal matter and gas going into the bladder and passing through with urine, causing recurrent UTIs. Not great if you ask me. Okay, so diverticulitis. You will be asking yourself, what do we do? Again, we are doing bedside stuff first. You will have OPS, as these patients, if they have true diverticulitis, are likely to be febrile. They may be hemodynamic instability. There may be going into sepsis if it's perforated. Now, the blood tests will be full blood count, which will show you raised white blood cells, raised neutrophils, and CRP will be raised, showing you that there is inflammation. Now, the gold standard imaging will be CT abdo-pelvis with IV contrast, especially if you want to look for complications such as perforation. Now, in terms of management, if it's concerned, you can start by keeping them nil by mouth. You will want to give them IV antibiotics and IV fluid if it's actually diverticulitis. And especially if they have those complications we've mentioned earlier, they may need surgery. They may need abscess to be drained, or they may need bowel resection if it's really bad. And we will cover what one procedure is in a few slides. Patient 5, it's 3 a.m. and you have had enough, but the patients keep coming. 55-year-old woman presents to the emergency department. Sudden onset left-sided groin pain. It is severe. She has history of hypertension controlled with amlodipine. Afebrile, 95 beats per minute pulse. Blood pressure is fine. You find an irreducible lump that is inferior and lateral to the pubic tubercle on the left side. It is extremely tender to touch. I've had a patient come into one of my GP surgeries in the past, very similar. So tell me, what do you think is going on?
Could it be a strangulated femoral hernia?
Amazing. Yeah, very well. Let's talk hernias. So hernia is defined as protrusion of viscera, so things such as bowel, through a weak point in the wall of the cavity that usually contains it. And typically we will be talking about bowel protruding through abdominal wall. Now there are a few risk factors: chronic cough or constipation, things which will increase the intra-abdominal pressure trying to push out the viscera out of the space. Now the patient with hernia, a simple hernia, will present with a lump, most commonly groin lump, as this is the most likely site to develop hernias, but other hernias as possible, as we will see in a minute. And there may have associated heavy, aching, dragging type of sensation. Of note, on your OSCEs, we've mentioned that you should say to the examiner that you want to examine the genitalia. You also want to say to the examiner that you want to examine hernial orifices, as if you don't do it, you will miss it. And if you miss it, patient is not going to do well. Now the hernias can be reducible, so the viscera can be pushed back into the abdominal wall, or irreducible. Now in terms of what can go wrong, it can become incarcerated, which is a term you may see, and this is where it's irreducible, you can no longer easily push it in. This means that this hernia is now at higher risk of obstruction. So you have your bowel in there, but the food is no longer able to go through it. So the patient goes into obstruction. And more worryingly, strangulation. So this is, as you've said correctly, it becomes ischemic, exquisitely tender. And with these ones, you don't want to try to push them back in, because then essentially you are pushing a necrotic piece of bowel into the peritoneum, risking perforation, peritonitis, and all the bad things. Now, inguinal hernia is the most common, and because of that, you need to know it. And the examiners like to ask questions about the anatomy. So the inguinal canal, which goes from the aces to the pubic tubercle, you have uh, and in the development, you have the spermatic cord or the round ligament going through it. Important thing is you have the deep ring, which is the physiological opening during the developmental period, and you have the superficial ring, which is located close to the pubic tubercle. Now, the key two differences, the two types of inguinal hernia that you may get asked about is the indirect inguinal hernia and direct inguinal hernia. Indirect is caused by the failure of closure of processus vaginalis. So the herniating viscera, so your herniating bowel, will enter through what was in the developmental period physiological opening, the deep ring, go through the canal and exit at the superficial ring. It will cause the lump that is superior and more medial to the pubic tubercle. Now, direct hernia, sorry, yeah, both of them will never mind. Yeah, so yeah, it goes through the deep ring, exits through the superficial ring. Indirect is very similar. However, rather than going through the deep ring, there is a defect in the posterior wall of the inguinal canal. It emerges, yeah, so it goes through the defect in the posterior wall, goes through the canal, exits at the superficial ring as well. Now, the examiners like to ask you how you would differentiate. So what you would do is you would reduce the hernia if it's reducible, press on the deep ring and ask the patient to cough. And if the hernia doesn't reappear, it's likely to be indirect as you are blocking the entry point. However, in direct hernia, you are pressing on a deep ring. This defect is still present. Therefore, on coughing, it would reappear. Now, in terms of the patients and your risk factors, it is typically male, but can be female as well, older, or can be very young in infants. Uh, Now, typically, it is superior and medial to the pubic tubercle. They tend to be reducible and they don't triangulate nearly as often. Therefore, you would list the patient for elective repair. Now, the femoral hernia are the rarer but more scary ones. They go through the femoral canal, and this typically is higher risk in females, again, older females. As you've identified it previously, it is inferior and lateral to the pubic tubercle. They are often irreducible at presentation, and there is high risk of them becoming triangulated. Therefore, these patients will be going onto the urgent waiting list. Now, we've discussed the inguinal and femoral hernia. There are a few other types of hernia that you have to be broadly aware of, but not in much detail. You have to consider where the abdominal wall is weak. You may have umbilical hernia or periumbilical hernia. You have your linea alba. You have your epigastric hernias and Spigelian hernias. And any site of previous surgery on the abdominal wall is a high risk of developing incisional hernia. Now, in an OSCE, you may get a patient which presents with this sort of oval hernia looking thing, which becomes more pronounced on them trying to bend forward when they are lying down. And this is not a true hernia, that is divarication of recti, typically due to stretched linea alba, but there is no actual defect, so the bowel is actually still within the peritoneal cavity, within the abdomen, within the abdominal cavity. And compared to the hernias, this has pretty much no risk of triangulation and is primarily a cosmetic defect. So this is the type of thing you are the least worried about. We have a few questions before we go on to the second section of the talk. Uh, Anybody wants to quickly walk through this one? Okay. So we have 16-year-old boy, emergency department. We have abdo pain, started center, migrated to the right lower abdomen, vomited once, um, feeling continuously nauseous. Observations not too terrible. Fever, yes, but the blood pressure okay, heart rate decent. Guarding right iliac fossa. Here we have the initial blood tests. So we think that he will need surgery. Anybody wants to volunteer what he will need before the surgery?
So, can you make a clinical diagnosis and give IV antibiotics?
That is very much correct. Well done. Yep. This patient, we have typical history and examination, neutrophilia, therefore the diagnosis is made, and you can give antibiotics in preparation for surgery. Now we have 35-year-old builder, SEU, concerns over tender abdominal lump, small lump on his belly comes and goes, but for the past few weeks remained prominent, acutely tender for 24 hours. No other symptoms, no past medical surgical history. Firm, slightly erythematous olive-sized mass directly in the midline, halfway between the xiphisternum and the umbilicus. Small defect in the linea alba. Who wants to give me their best bet on the diagnosis? Mm, Okay, so this one is a triangulated epigastric hernia. Now, I assume you probably identified that whatever it is, it's triangulated. Kind of, let's go step by step. So, tender lipoma, uh, unlikely. Weird presentation for a lipoma. Lipomas tend to be older population. They rarely get tender, and they wouldn't really be erythematous. It just doesn't really fit. Now, divarication of recti, as we've just discussed, it doesn't really triangulate. It is in the midline, but it's typically much more oval and larger mass. And yeah, it just wouldn't triangulate. Spigelian hernia could be, but the location is not great. Pigilian hernias tend to be lateral, kind of. If you think about the six-pack muscle, it tends to be on the side and typically lower down. Now, epigastric hernia fits with the location between the xiphisternum and the umbilicus. And this one is likely strangulated as it's starting to get tender. Now, it was probably incarcerated for some time, for a couple of weeks, but now it's becoming acutely tender, pointing towards strangulation. Okay, let's see whether this one will have better uptake. 63-year-old female, severe colicky abdominal pain getting worse for the last 5 days. She has history of diverticular disease. On examination, found to be tender in the left iliac fossa. No guarding. Temperature of 38.3 degrees. Heart rate of 103. Otherwise, normal signs. What investigations do you want to do first?
The FBC and the CRP?
Well done. So yeah, absolutely. And the key thing to think about here is if you're thinking to yourself, why not CTAP? Good point. But the questions ask you which you complete first, and you will go in the order of bedside test, followed by blood tests, followed by imaging. So you will start with FBC and CRP to see whether these diverticular are inflamed. Are we in the diverticulitis territory or just diverticular disease? Now we have another question. Which of the following is correct regarding direct inguinal hernias?
Is it C?
That is correct. Now we have 23-year-old patient, female, surgical assessment unit, severe slow onset left iliac fossa pain, left on examination that pain is confirmed. She denies being sexually active in the past year. You find signs of peritonitis that say that she has a bit of guarding. So what is your next investigation?
C?
That is correct. That is correct, absolutely. And yeah, again, the protocol still stands. Female plus our childbearing age plus abdominal pain, especially lower abdominal pain, but pretty much any abdominal pain, equals pregnancy test. Uh, you may assume immaculate conception, but you have to exclude ectopic immaculate conception. All right. Now we will start with the second bit about the central abdominal pain. We are going to the bowel. We are going to talk about the important bits, the small and large bowel obstruction, the rare but dangerous bit, the mesenteric ischemia. Now, we've talked about appendicitis. remember that central abdominal pain is seen in the the first bits of appendicitis. So remember to consider appendicitis still. And triple A can also present with abdominal pain, but we won't cover that today. And we'll also cover a bit of the scary but chronic stuff. Now, we have another patient, 65-year-old woman, ED. She has central abdominal pain and vomiting. She hasn't really opened her bowels for the past 2 days. She feels really bloated. She has history of two previous cesarean sections. Abdomen visibly distended, consistent with what she says, and tinkling bowel sounds on auscultation. What is the diagnosis?
Bowel obstruction?
Very much so. So, in bowel obstruction, we have, as the name suggests, food, fluid, gas cannot go through. We have back pressure, the segment of the bowel which is proximal or upper to the site of obstruction becomes dilated. Now, the classical symptoms of obstruction are the colicky abdominal pain, comes and goes, abdominal distension, vomiting, and absolute constipation. Now, the last two uh, may give you a bit of a clue. Now, and they are not always present. Depends on where the obstruction is. Now, small bowel obstruction typically presents with a lot of nausea, a lot of vomiting pretty much from the start. Um, they will be unable to keep anything down, vomiting pretty much as soon as you give them anything. Now, they may still be passing gas as they still have quite a lot of bowel downstream that is left and open and potentially working, but nothing goes in. Now, the large bowel obstruction presents more with the absolute constipation. So they aren't passing any stool, but they aren't passing any flatus as well. So no gas coming out. And initially, the vomiting and nausea may be relatively mild or absent until much later when everything pretty much fills up. But essentially, based on the clues in the history, you can try to determine, not with 100% accuracy, but point towards, is it more small bowel obstruction? Is it more large bowel obstruction? On examination, you will see that they are distended. They will look uncomfortable most likely, and there will be tinkling bowel sounds or more classically absent bowel sounds. Now, in terms of investigations, the kind of classically, you will kind of, especially in the older days, you will go with abdominal X-ray or the erect chest X-ray if you are trying to see whether there is any perforation. Now, CT abdo-pelvis with IV contrast is definitive and gold standard, and now much more common with how democratized the CT has become. Now, in terms of management, again, you can structure management of conservative, medical, surgical. Drip and suck is what you will do first. So this means that you will keep them nil by mouth. You will insert nasogastric tube to decompress the stomach. And you will give them IV fluid. And you will observe them for 48 hours. As hopefully, especially in the small bowel obstructions, this may be enough uh, to relieve the obstruction and they will just recover. Happy days. Now, medical management. You can give them gastrographin, which is pretty much a type of contrast material, but it also stimulates the peristalsis. And you do abdominal x-rays to track the gastrographin, and that may relieve the obstruction. Now, if that fails, there's also the surgical management, and essentially try to resolve whatever is going on. It can be adhesionolysis if it's like this lady with two previous cesareans that has a bunch of fibrous scars in her abdomen, removing those and hoping for the best. You can try to do a hernia repair if it's an obstructed inguinal hernia that's causing the problem. You can try to remove the tumor if it's, let's say, if it's unfortunately a bowel cancer that's just blocked the lumen of the gut. Now, you will need to read a chest X-rays in your OSCE potentially. And one of the signs you want to look for, one of the review areas is under the diaphragm. And if you see air under the diaphragm, this suggests perforation and need for senior input. Now, in terms of abdo X-rays, you are not going to be diagnosing much in abdo X-rays, but they are still relevant in the bowel obstruction, and they are quite a good way to visualize bowel obstructions. Now, the small bowel obstruction is typically caused by adhesions or hernias, potentially inflammatory strictures in patients with Crohn's disease. Now, on X-ray finding, now on X-ray you will find the dilated loops of bowel, and the clues to point you towards a small bowel obstruction, like in here, central position rather than peripheral. There are multiple twists and turns, and they tend to be quite tight. And the key one is valvulae conventis. So you can see these rings that go all the way through from one edge of the bowel to another edge. And these are characteristic for the small bowel. Now the large bowel, unfortunately, here you have to consider malignancy, especially in the older patient. We will talk about volvulus on the next slide, I think. Um, Potentially can be caused by diverticular disease if they form inflammatory strictures. And IBD can also result in strictures which cause obstruction. Now, the abdo X-ray will also show dilated loops of bowel. Now, they will tend to be peripheral, but not, there may be a section going through centrally. They will typically have, the turns won't be as sharp, it will be less twisted. And although you can see the haustral folds, you can see that they don't go all the way through. They stop, like you can see there is a gap here, and several gaps. This suggests that this is a large bowel that is distended. Now, volvulus typically happens in your elderly population with multiple comorbidities, things like Parkinson's disease, malignancies as well. This is when the bowel twists on itself, and radiologically on abdo X-ray, you will see a coffee bean sign, and they will most likely need surgery. Now, we've talked about the bad stuff, but we also need to talk about common stuff, and we need to talk about paralytic ileus, aka the pseudo-obstruction. This is a non-mechanical obstruction. It is the typical, we can talk about the paralytic ileus in the small bowel, and essentially, bowel is a bit moody, maybe less moody than the pancreas from last week's lecture, but if you handle it during surgery, it can get a bit lazy, a bit fed up, have a bit of teenage angst, and decide to stop working. Uh, And this is common post surgeries. That's why when you go on surgical ward rounds, the key question is, have you passed any gas? It can also be associated with the pancreas. So pancreatitis can cause inflammation, and the inflammation can trigger paralytic ileus or in electrolyte derangements if you're in your unwell patients. Now, the large bowel can also get unhappy, especially in orthopedic surgery with hip replacement. However, luckily, those primarily resolve with conservative management. Now, we talk about the chronic conditions. Let's start with the colorectal cancer. Most common type of colorectal cancer is adenocarcinoma, as you will know from LabMed. There are several risk factors. You have your monogenic syndromes, such as Lynch and adenomatous polyposis coli. However, these are rare in the grand scheme of things. But still ask your patients about family history of bowel cancer, especially if your patient is younger than you'd expect. In addition, the inflammatory bowel disease, both UC and Crohn's, are a risk factor for bowel cancer. Diet that is high in red meat, low in fiber, uh, maybe due to higher, contact time of toxins, things like that. Difficult to tell, but it is definitely a risk factor. Smoking, as with most cancers. Obesity is associated with bowel cancer. High alcohol intake, primarily age. Although there are cases, you won't typically find 20-year-olds with bowel cancer unless they have one of those, especially this one. And if you, now this is more of a sign than a risk factor, but LabMed likes this question. If you have a patient with infective endocarditis, cultures isolate Strep bovis, you need to check them for colorectal cancer as it is highly associated with presence of colorectal cancer. Now, the presentation of the patient. They may be asymptomatic and presenting through the screening program as I have seen in the past, but if they do have symptoms, they may complain of change in bowel habit. They may have rectal bleeding. Now, it can be very minor, so they may not see it. It may just present as iron deficiency anemia of unknown cause in an older person. There may be weight loss, unexplained abdominal pain from the tumor pressing onto other structures. You may feel erectile mass, or it can present acutely if the tumor gets so large it blocks off the lumen and they present in large bowel obstruction. And again, you don't need to know that, but a constellation of these symptoms plus minus the clinical judgment constitutes the criteria for referral onto equate pathway. Now, how you will investigate these patients? The key thing you want to say is you want to do a fit test, looking for a trace of looking for blood in the stool. And also you may want to do bloods, and these would be the bloods such as full blood count and ferritin. Iron deficiency anemia would be consistent with potential bowel cancer. Now, the gold standard diagnostic, if you get asked about, is the colonoscopy, in which you throw a thread, a colonoscope, which is essentially has a camera and a fiber optic, through the entire bowel, going into terminal ileum. And then you image the bowel as you go back and you biopsy any polyps. You take out any polyps you see, and you biopsy potential tumors if you find. Now, CT cologram is an alternative in a patient that needs a colonoscopy. but either they are too frail to tolerate a colonoscopy or just unsuitable for colonoscopy for other reasons. Now, if you find a tumor and the histology confirms that this is bad, you will do staging. So CT chest, abdo-pelvis, essentially looking for any metastasis, commonly in places like liver, is quite a common site for colon cancer to metastasize to. Also, the CEA tumor marker to essentially try to figure out the tumor load. Now, as I've said, oftentimes the patients are asymptomatic for quite a long while. That's why there is the bowel cancer screening program. So people aged 60 to 74-year-olds receive a fit test, as we've mentioned, looking for blood in stool every 2 years, and they can provide a stool sample and send it back. And if it's positive for blood in stool, they get referred on to 2-week wait colonoscopy to try to look for the source. Now, although you don't need to know a lot about treatments, it helps to understand what different surgeries mean. They are in part derived from the blood supply to the large bowel, and with your surgical, you can try a surgical resection aiming to cure the cancer. The common sites will be right hemicolectomy, looking to take out the ascending colon and the hepatic flexure. You have left hemicolectomy, where you take out the descending colon and the splenic flexure. Anterior resection is where you take out the sigmoid colon, and abdomen perineal resection, where you take out the rectum as well. Now, these are less performed in the cancer scenario, but are still relevant. You can do a total proctocolectomy, for example, in patient with ulcerative colitis to try to cure them of their ulcerative colitis. Or there is the Hartmann procedure we mentioned earlier, and this is typically an emergency procedure resecting the sigmoid colon, for example, due to very bad diverticulitis. So you take out the sigmoid colon, but because everything's inflamed, the blood supply is not great, and it's just a nasty mess at this stage. You don't reconnect the two ends, you don't anastomose. You leave the rectal stump, you suture it shut, you bring out the remaining bowel as an end colostomy, and you leave it for the patient to recover, and you can attempt to re-anastomose the two ends at a later date when the patient is no longer acutely unwell. If the patient is not a candidate for surgery, you can try chemotherapy and radiotherapy to control the cancer spread. Now, we've mentioned end colostomy. Now, stomas is something you may get asked in your exams. And stoma is very much an artificial opening in the abdominal wall, and you are connecting a segment of the GI tract to the external environment. This is typically because whatever is downstream is currently not capable or just not working for the patient to conduct the fecal material. Now, there are two types of stoma in regards of the segment of the gut. There is the ileostomy and colostomy. Here you can see an ileostomy, which you can see based on the fact that it is spouted. You have a segment of the bowel lining sticking out. This is to help to prevent the irritation around of the skin around the stoma, as the as the small bowel contents, which is pretty much what you get, are quite corrosive to the skin. Whereas colostomy, and also it's on the right side, which also points towards ileostomy. Colostomy would tend to be on the left side of the abdomen and would be flush with the skin, as the well-formed stool that comes out of the colostomy is not as irritating to the skin. Now, in terms of the types of the stomas, we have loop stomas where we bring out the loop of the bowel to the skin and we open it, but we leave a side of it connected. So we have both the proximal and distal segment draining. And this is typically done in case where we want to reconnect the bowel later. Now, end stoma is where we just have the proximal bit, the functioning bit coming out, and something happened with the other bit. Either like in Hartmann procedure, it was sewn shut, or it's no longer there. And end stomas, apart from the Hartmanns, are typically intended to be permanent stomas. Tying things up, we've mentioned imaging of the GI tract. So we have some gold standard and investigations you may want to use. So last week we discussed OGD, which images the esophagus, stomach, and a bit of duodenum. So this allows you to see the upper GI tract. We have the colonoscopy. So we go through rectum, through entirety of the large bowel, and ideally into terminal ileum as well. And this is gold standard for the colon cancer diagnosis. Now, we also have the flexi-sig. We go through the rectum, and we only visualize the sigmoid colon. Now, this is more helpful in acute conditions, as it has lower chance of inducing a perforation. We have a patient that decided to finally show up. 75-year-old man, sudden onset severe generalized abdominal pain, vomiting, single episode of bloody diarrhea. He looks unwell and is in uncontrolled atrial fibrillation. The abdomen is diffusely tender, but it is still soft. It may be a bit more difficult, but if anybody wants to give it a shot, talk me through what you think is going on. If you're still awake.
Could it be mesenteric ischemia?
Very well done. Very, very well done. It is indeed mesenteric ischemia. And what is going on? In mesenteric ischemia, you have to remember that you have your bowel, both small bowel and large bowel. They need their blood supply. They need arteries. And these will come off of the superior mesenteric artery. You have your inferior mesenteric artery as well. And if you get a blood clot causing blockage of either of those or one of the branches, you have a portion of an ischemic bowel. You have central abdominal pain. There is diarrhea, potentially with bleeding from the necrotizing bowel. There is fever, and the patient will be systematically unwell because necrotizing bowel. Now the acute patients, now the patient can present acutely with sudden onset severe symptoms. Oftentimes they will have history of atrial fibrillation. So you have thromboembolism that goes down the aorta. Luckily it didn't go into the brain to cause a stroke, but now it's traveling down the descending aorta and it goes into let's say, into SMA. You have sudden onset severe abdo pain. Now there may be an element of chronic mesenteric ischemia, and this is your vasculopath who has atherosclerosis, and atherosclerosis can affect SMA as well, and the pain tends to be more colicky, Worse after eating, because if you think the bowel needs good blood supply, good oxygen for peristalsis and for the absorption of nutrients, and it's not getting that, so you have increased metabolic demand with insufficient vasculature, so you get a gut claudication. Now, on investigations, the important kind of first line bedside investigation is the VBG, which will show you marked lactic acidosis. And the imaging, the gold standard is CT with contrast, primarily CT angiogram to visualize the vasculature. Now, the management in acute setting, it will be laparotomy. Most likely you will want to excise that necrotic bit of bowel. And chronic will be your management of cardiovascular risk factors. Don't worry, we are slowly getting there. We are going on to inflammatory bowel disease, and I will try to be as fast as possible. Now, we've discussed it a bit in the past, but let's go again. Typically, the patients with IBD on first presentation is young. It's a teenager to early adult. The two key types are the Crohn's disease and UC, as you will remember from LabMed. And your differentials will be IBS or celiac disease. Now, in terms of this patient, how you differentiate between IBD and these two is your patient with IBD will have raised markers of inflammation and raised fecal calprotectin. You have your patient with raised fecal calprotectin. What is it? In Crohn's, you have family history, yes? Now, smoking is a risk factor, so the vignette can say that the symptoms got worse when the patient started smoking. In contrast, in ulcerative colitis, smoking is actually protective. So the vignette may be saying that they have sudden onset of those bloody mucus diarrhea and they've stopped smoking 2 weeks ago. Don't tell your UC patients to start smoking, pretty please. So yeah, in Crohn's, it tends to be more of an insidious, kind of continuous process. They may get episodes of abdominal pain. Right iliac fossa is classic because the terminal ileum is the most commonly affected site and it radiates to the right iliac fossa. They may get diarrhea, which typically there isn't much blood in it. They tend to be systematically upset, so the patient will present with fatigue, weight loss. If they are children, they may have stunted growth. And perianal disease points strongly towards Crohn's. So multiple perianal abscesses, perianal fistulas are strongly suspicious of Crohn's disease. In UC, it's dramatic onset, it's all fireworks. You have a lot of bloody mucousy diarrhea. There may be fecally incontinent, nocturnal defecation, tenesmus, aka feeling of incomplete emptying after going to the toilet. Pathology, I'm not going to dwell too much into it, that's LabMed, but in Crohn's, anywhere in the GI tract with skip lesions, on colonoscopy, which is gold standard for diagnosis of both, you can get cobblestoning, and the inflammation is transmural, so all the way throughout. In UC, it goes from the rectum and goes towards the ileocecal valve, but it doesn't go throughout beyond the large bowel. It tends to be continuous as well. You may get pseudopolyps on colonoscopy, and the inflammation is limited to mucosa and submucosa with abscesses. Now the complications. In UC, you can get toxic megacolon, so very dilated bowel on the X-ray, which can perforate and cause sepsis. There's increased risk of colorectal cancer as well. Of the extraintestinal, you have primary sclerosing cholangitis, which is more associated with UC, which can lead to cholangiocarcinoma. In Crohn's, you have perianal disease classically, skin tags, fissures, fistulae, abscesses. You have aphthous ulcers. Remember, it's disease from anus to the mouth. So large aphthous ulcers in areas without direct trauma, like the roof of the mouth. You have strictures, which can cause small bowel obstruction. And you can get fistulae, you can get abscesses, it can perforate. Now, for both IBD types, you can get inflammation of the joints. You can get skin rashes, such as erythema nodosum, which pretty much looks like these bruises, and they are painful as well, but there is no history of trauma. You get pyoderma gangrenosum, a nasty condition, and you can get clubbing of the fingers. In addition, you can get eye condition with either. Now, with UC, this tends to be anterior uveitis, with Crohn's episcleritis. The details will be covered in year 5. But in terms of taking history from your IBD patient, it's good idea to ask about joint pain, any rashes, any problems with your eyes, any eye pain they took you to the hospital. So I have some extra questions, but at this point, if you want to scan the QR code and give me some feedback and have it ready so that you can give me feedback later, that would be fantastic. That's also a requirement to get the slides/access to the recording. So highly recommend doing that. But please stay tuned as I have a few extra MCQ questions for revision after that. Okay, I hope that everyone managed to scan that. I will show it again after the questions. Let me know if you need to head off and haven't scanned the QR code yet. But let's get to the questions. So, 46-year-old woman, abdominal pain for the past 5 days, cannot tolerate any food, only minimal liquid, no bowel movement for 4 days. She had C-section 10 years ago, appears dehydrated, distended abdomen. That's your abdo X-ray. Now, what is the most likely underlying cause of this patient's presentation? Any volunteers?
Adhesions.
Very good, very good. So yeah, so this question, as questions in AKT are likely to require a two-step process. You have the history, which is already suggestive of small bowel obstruction with the very significant nausea and vomiting. The abdo X-ray with valvae conniventis confirming the small bowel obstruction. And given the patient's history of C-section and no other significant history in the past, the adhesions are the most common cause of small bowel obstruction. 21-year-old male, 3-month history of intermittent right iliac fossa pain. He has episodic diarrhea, lost 2 kilograms in weight. He has some mouth ulcers, smoked 20 a day for 6 years. Again, right iliac fossa tenderness, and he is febrile. What do you expect to find on histology?
B.
That is correct. So again, two-step process. you identify that it's most likely Crohn's, especially things like mouth ulcers, mouth to anus inflammation, smoking history, as well as weight loss and more indolent presentation, such as Crohn's disease, and all of the goblet cell depletion, abscesses, mucosal inflammation are characteristic of UC, and villus atrophy is characteristic of celiac disease, which we didn't cover, but it was covered in the lab med content as far as I remember. But the goblet cell hyperplasia is a feature of Crohn's. So another patient, she had appendectomy yesterday, as she had appendicitis. It was successful. Now vomited several times, has severe nausea. On examination, distended abdomen, surgical wound looks healthy, no discharge, no erythema. The only really thing is distension, no bowel sounds. Not opened the bowels yet since the operation. The investigations are fine. So, what is the most likely diagnosis? This is a one-step question.
E.
That is correct. If you think about it, things such as perforation, infection, intra-abdominal access, the wound wouldn't look as great, and she would have at least some abnormalities in the full blood count consistent with infection. Now, the simple constipation wouldn't cause you to start vomiting just after a day or two, but it is very consistent given her history of recent surgery with paralytic ileus and a small bowel going on strike, resulting in a small bowel, shall we call it pseudo obstruction or function or non-mechanical obstruction of the small bowel. So that is correct. Patient Bethany Clark, 24-year-old receptionist, referred to us, general surgeons. She failed medical therapy for acute attack of ulcerative colitis. Disease extend from rectum to splenic flexure. We have slot on the emergency theater list for this afternoon. Now this is a bit above year 4 as we are talking about treatments, but who wants to suggest a surgical procedure for this acutely unwell patient with UC? Okay, it is indeed a question slightly above year 4 contents, which is perfectly fair. So in this patient, out of the options, the total colectomy, ileostomy, and rectal stump formation is the most appropriate. The thing to consider, essentially you have patient with ulcerative colitis, and it goes to the splenic flexure. So Hartmann's would be an acute procedure, but it doesn't cover, enough of the bowel to cut out all of the inflammation. Right hemicolectomy wouldn't cover the sigmoid colon, which is affected. Left hemicolectomy, right hemicolectomy wouldn't cover anything that's affected actually. And left hemicolectomy wouldn't cover the sigmoid colon. Now, panproctocolectomy is something you could do in a patient that is stable as a curative management, but this is acutely unwell patient. And especially ileal pouch formation is not something you will do in an acutely unwell patient. So you will take out the entire colon, do an ileostomy, and do a rectal stamp, which you can manage later. And then the options are either to, when the patient is well and it's an elective procedure, you can either try to reconnect the ileum to form the ileal pouch, or indeed just resect the rectal stump and give the patient permanent ileostomy. Now, thank you so much for staying. Apologies for running over for 2 minutes. In case you haven't filled out the feedback form yet, please do so now. That is a requirement to get the slides and the recording. Let me know if you have any questions. I will do my best. I am not a surgeon, but I will try to do my best. And thank you so much. Thank you for joining me today.
Thank you so much. Do you mind going back to the second slide?
Second slide, like all the way in the presentation to second slide.
Yeah. Sorry, the one with
Okay.
all the differentials for abdominal pain, or fourth one. Yeah. Thank you.
Okay. No worries. Do you have questions about anything specific?
No, I just want I kind of missed it, so I just wanted to see it again. But thank you. That's yeah.
No, absolutely.
Thanks.
That's fine. Yeah. If you think about upper three quadrants, these are typically your upper GI stuff, which we covered last week. Now, the sides are kind of unlikely to be GI related. These are typically the kidney stuff, the renal colic, and pyelonephritis, which we'll cover in your urology revision sessions. Now, the umbilical, we've talked about bowel obstruction, start of appendicitis, mesenteric ischemia, and the lower GI, classically the lower bits. Remember about the ectopic pregnancy and the testicular and ovarian torsion, especially on the flanks.
Yeah, sounds great. Thank you so much. Appreciate your time.
No
Thanks.
worries at all. Okay. Let me know if you have any other questions, and hopefully you filled out the form. Thank you.